So I am here with Dr. Rishi Manchanda, who just gave a keynote speech at our annual expo, Foothold Technology Expo 2015. It was a terrific, dense, thought-provoking speech on the social determinants of health, and so I thank you for giving me 5 more minutes here before you got to take off. Just give us a little background before we get into some of the details of it. Why do you do this? Why did you become a doctor? What got you going in that direction?
I got into this because not necessarily for the love of biology, although that's something that's always fascinated me, but because I saw what was possible in working in community health. Mm-hmm. And that came about when I was in college. I had a chance to go visit a part of the world in southern India that I learned about. It was a state called Kerala. These guys had figured out in one of the poorest countries around how to provide services in a way that improved infant mortality rates, right, and got total literacy. Essentially, had figured out how to provide impressive social development, but with very little money. Mm-hmm. And for me, that was an outlier, right? Didn't really kind of comport with what, seemed to make sense with you need more money to get more outcomes kind of work. And so I said that I want to go there and find out. So I went there between my junior and senior year of college. I got so hooked on what I was finding there that I went back again. And what I found was a state, part of the world that had done what other parts of the world have figured out, and some parts of the U.S. too, which is that if you're really going to improve things like the number of infants that you can prevent from dying too early, or improve literacy rates, or improve the general health of the population, it requires a holistic global approach rather than kind of more pills or procedures necessarily. But while that understanding is not, it's not rocket science, right? What I saw firsthand were people who were on the front lines of providing services, who happened to both work on the ground, but then also work in this kind of community-oriented way, and some of them happen to be doctors. Mm-hmm. And I said, well, that's the type of doctor I want to be.
So let's skip ahead then. Your talk focused a lot around the idea of a social determinant of health, and how it's not that we should be discarding what we've learned about biology and drugs and surgery. All those things are important. All those procedures and pills, they can really be life-saving. But that we're forgetting, to our detriment, we're forgetting all the different social determinants of health. And it ends up that a lot of our technology are just Band-Aids on a problem, the cause of which is still unaddressed, right?
Right.
So that was basic. So how are we seeing this? How are you seeing this? Or how are you actually bringing this into practice? I know you have a clinic in LA. Are there other places around the country where you see this kind of an idea beginning to actually take hold?
Yeah, so it's happening in many parts of the country. It's been happening for a while as well. The story of bridging the divide between sick care systems and kind of a community health approach has been a long-standing part of the story of American healthcare or medicine. It's been called different things, from community-oriented primary care, social medicine, and there's a lot of different roots to this. I use the term upstream in part just to reinvigorate this, mm-hmm. and also to be able to describe the people out there who are innovating, the upstreamists. And what I've come across are stories like, sometimes not even like seasoned veterans in healthcare, some young kind of new clinicians entering the workforce, like a resident physician I met out a couple years ago in San Francisco who built a financial literacy clinic, a program into his resident clinic, where they screen people who are having problems with their finances, with managing their finances, getting access to some of the kind of public benefits that are out there. Knowing how to save money, right, and creating the structures to do that. He realized that was a huge driver for why they weren't taking their medicines or why they were still sick. And so he couldn't find other resources in the community that were touch points in the way that his clinic was. So he found the partners that were doing this in the community and brought them into his healthcare clinic. And that's a great example of what Upstreamists do, right? People, for better or for worse, utilize the healthcare system. That's the door that gets opened a lot more frequently than sometimes in the social services side, unfortunately. Yeah. And it's in part because we haven't done enough investment upstream.
Exactly,
right?
Yeah.
But that's also, therefore, as a pragmatic organizer, right, as a change agent that we all want to be, it means that we have to go to where people are. And if they're going into the doors of a doctor's office or the hospitals, then that's where you put your resources to be able to take somebody who's sick and make them healthy.
Having to create or encourage or establish an infrastructure in which that can happen, right? If we rely on the good hearts and souls of individual practitioners like this
Right.
person in San Francisco, it's going to be a very slow process, and we may not ever get to full rollout, right?
That's right. The funny thing, we will guarantee that we won't.
Yeah,
right?
exactly.
Because if all we're doing is banking on the heroism of a few kind of vanguards that's out there, while we can celebrate them in storytelling and the media, and they should be celebrated because that is not for the faint of heart.
Right.
That is not upon which you build a system.
Exactly.
Right, of change.
Yeah.
And the last thing you want is to bank on the future by putting everything on the shoulders of one or two heroes.
Yeah.
Right? But what is really instructive, therefore, is looking then at the structural changes, the system changes, the methodologies they use. And that's where I think, in addition to all the interesting interventions that are popping up, it's really, for me, thinking about how to create this new ecosystem of connected care, right, of an upstream system, by looking at the methodologies. Like what really makes those heroes, those upstreamist kind of innovators, really effective.
Yeah.
And what it turns out is true is that when they really get traction, it's because they've altered the system, not because they're some sort of hero that happens to do a one-off experiment.
And so now I'd like to introduce you to this year's keynote speaker, Dr. Rishi Manchanda, who will give a first-hand account of his experience incorporating all aspects of healthcare. He's a one-person embodiment of this connected care idea that we've been talking about at Foothold for a while, behavioral, physical, and rehabilitative, into his treatment philosophy. Dr. Manchanda calls himself an Upstreamist, which he will hopefully define for you, and looks at how health begins at home and in the workplace, and is influenced by the social and environmental factors of our everyday lives. So without further ado, I'd like to introduce Dr. Rishi Manchanda.
Good morning. It is, Marlowe, thank you, and thank you to everybody here. It sounds like an incredible, I want to stick around the entire time you guys are here as well, because a lot of what you do is the stuff that I care more deeply about. Instead of prescribing statins, I really care about how to more effectively connect patients to homes or to jobs. And so I have a sense that this is the right room to kind of talk about some of that work. I'm going to do one housekeeping thing. Where's Elizabeth? You and I are going to be tag teaming? All right, great. So what I wanted to share with you today, before I go into the slides and everything, is just tell you about why I'm personally really excited to be here with you guys. I'm a primary care physician. I practice and live in Los Angeles. I had the privilege of being released from my training eventually several years ago, and then getting out into the field and working in South Central Los Angeles for about 4 years, where I did a lot of work with incredible people on the front lines of a very fragmented healthcare system, trying to figure out how to improve outcomes. We did a lot of work and discovered that, of course, doing that was about connecting people to housing resources and food resources just as much as it was about getting access to traditional specialists. I then went on, after 4 years there, to the VA hospital in Los Angeles, where I started a clinic for homeless veterans, high utilizer homeless veterans coming in and out of the emergency department. 3 nights a week, I set up shop in the ER, and we just used coffee and donuts to, not for the vets, but really for the triage nurses, to allow us to be there. Anybody work in the VA? Anyway, you'll understand why coffee and donuts are the currency of getting stuff done in places like the VA. But we effectively showed that with a little sweat equity, again, caffeine and some sugar, we could figure out how to drop utilization among the sickest of the sick homeless veterans by 70% in terms of the ER use. But more importantly, we planted a flag and said that what we would do is improve housing outcomes. A clinic staffed by a doctor, at that point an LVN and a clerk, because that's all the line item was specified for. We managed to figure out how to demonstrate to the hospital system that what we really needed was a social worker and, in fact, a lawyer. And that's what we ended up doing. And these are the reasons that I enjoy medicine, because I get to work as part of teams that allow me to be a doctor, but allow me to have impact because I work with people who address the bio, psycho, and social elements of health. So I don't embody connected care, but I'm proud to be part of a growing number of healthcare providers who are increasingly frustrated with their inability to really have impact without being part of a team of people that can do it. So with that said, I can go on for a while to tell you my street cred out there, but this is something that I live and breathe, and I think you guys do as well. So let me just tell you a little bit about the problem. Not from a tech perspective necessarily, but give you a sense of the context of the pain points that I see every day from my world in the biomedical enterprise. And then in that context, maybe describe a certain methodology that I've been part of promulgating, and then hopefully get your input about how your services, how the technology platform you use can really help to bridge that divide between health and healthcare. So the next slide, if you don't mind. This slide is really a story of the current pain point among a lot of healthcare providers in the physical health sense. I'm a primary care pediatrician in a rural part of California. I care about upstream issues. I'm just going to cut to the chase, right? You can read it there. This is somebody who emailed me and said, I understand upstream approach for many years, but all my attempts fall by the wayside. I have no resources. How to manage, please help. This email was, with the exception of the small area in the parentheses there, this is exactly how I got this email a few months ago. A primary care doctor on the front lines in a small community clinic in rural California, emailing between her 30 patients in a quick, rapid-fire fashion. She barely had enough time to even send off the email, right? You can see her short, fragmented sentences. When I saw when I got this email was somebody who was a kindred spirit, because I know exactly the pain point that this person was feeling. What I saw here was pain, right? And a plea for help. This story, does this resonate with anybody that you've seen or worked with? This is a common enough story. It is incredibly common, right? Far too many of our healthcare workforce, and I mean the workforce writ large, are burning out. The very people who we need on the front lines are the ones who are starting to step back from the precipice of being able to achieve real impact because we've exhausted them. And part of the reason we've exhausted them is because I think fundamentally, while there's a lot of reasons out there, one of the core components is that we haven't figured out how to address that pain point. She knows the upstream approach matters, and you'll understand how I use the Upstream Parable in a second. But it's not that she doesn't know that issues like housing or jobs or all the issues that affect the patients that she described. It's not that she doesn't know that those things matter, but she doesn't have the tools or the support and the system to do anything about it. There is an upstream efficacy gap, right? She doesn't know what to do about it. The reason this is important is because, if the next slide please, Elizabeth. Because of course what she's speaking about is the fact that there is this awareness. As you can see over here, this is a slide just recapping what I think all of you know, and we'll just pause it over here. The slides might advance on their own, but what this pediatrician knew is that the social factors are the predominant driving force for health outcomes. Everybody here in this new room knows this, right? I'm going to skip over this, but let me just give one salient example of what this looks like. There was a wonderful study that was done in the United Kingdom, a secondary data analysis. They reviewed over 40 million records. And the researchers were looking at a lot of variables, but the specific focus was on looking at the incidence rate ratio of death from heart disease. In other words, how many people were dying from heart disease, and was that at all correlated with your exposure to green space, parks and trees? They controlled for a lot of other variables for those researchers in the room, like they did a pretty stand-up job in terms of how to do this research. And what they found was that after controlling for income and education and all these other factors, the closer you lived to green space, parks and trees, the lower your risk or the rate of death from heart disease. And what they found also was that in each group, as you got closer and closer to green space, in each community, the disparities between the richest and the poorest also started to diminish. So that the likelihood that you were going to die from heart disease not only decreased as you got closer to green space, but the disparities between those who have and those who have not also diminished over time. Again, this is a correlation study. Causation is hard to argue because it's that kind of study. But here's the most important point about this. Other studies that look at heart disease and risk of death from cardiovascular disease in medicine really point a lot to the factors in the biology, right? Let's look at your cholesterol. Let's look at your blood pressure. Let's look at things like that. And there is an incredible amount of rigor that is in place to be able to guide service providers like myself about how to start to modify those risks, right? your blood pressure, your cholesterol. Multi-billions, trillions of dollars go into now all of the pills and procedures that do that. And there is incredible rigor that is demanded upon by your providers, including myself, right? To say, here's how we actually take you who have high blood pressure, or you who have high cholesterol, and walk you through the algorithm to get you to the right treatment to modify that risk. But there is no rigor, there is no taxonomy, there is no kind of set of guidelines that advise me how I can prescribe a park, right? And if the studies from that study from the UK, 40 million lives, and that correlation is even indicative of a little bit of causation, right? In other words, if being closer to green space for a community, rich and poor, can help decrease your risk of death from heart disease, then why are we not demanding the same level of rigor from our healthcare providers when it comes to prescribing access to a park as there is access to pills or procedures? It sounds Pollyannish, but if you let science be the guide, right, there are certain basic kind of questions that we should start asking ourselves when we talk about expectations out of the healthcare system writ large. And all of those expectations are grounded in this knowledge that the social factors really do matter. This basic slide is from a major study that was put out in 2007 in the New England Journal of Medicine. And what it essentially said was stuff you guys all know. Social factors, including where you live and where you work and the environmental exposures, as well as their impact on your behaviors, how you live, how you eat. All those things had more than 5 times the impact on premature death than anything in healthcare, pills and procedures. Now, when I share this with a lot of my colleagues in medicine, there's this look on their faces like, great, you're telling me that I'm irrelevant, right? The 10% wedge. Thanks a lot. When I share it with people who are not in the medicine space, they say, duh, right? This makes total sense. But here's the interesting point. Number one, there's this weird false debate that occurs sometimes. You may hear this, you may even have participated in this sometimes. It's the Miller Lite kind of taste great, less filling approach, right? Debate, remember that? All right, so on one side you have people who say, you know what, poor outcomes and health are really driven by poor choices. It's people not choosing well how to eat, how to live, how to work. The behaviors are just wrong. That's the problem. Why can't they learn how to eat healthier or live healthier? Live in a community that's healthier. And then you have the other camp that says, no, it's really all about the structural determinants that go as deep as racism and poverty and power, as well as other dynamics in terms of how we've structured access to parks and neighborhoods. The structural determinants versus the behaviorists, right? And the reason it's a false debate is because we know that where you live and where you work dictates your choices about how you live and how you work and how you eat. As a case study, if we took all the chairs out of this room, maybe left about 4, and then invited you all back in to listen to this wonderful talk by this guy from LA, some of you would act very differently. Some of you would leave. Some of you would maybe, take those chairs and pull together around them. Some of you would share cheek to cheek on a seat, right? Your behaviors would be a little different, mainly because we had changed the structure of the environment that you were occupying, right? You would make different choices and behave differently because we altered the environment. It is no longer adequate for us to buy into that false tastes great, less filling debate any longer. If you participate in it or if you see it happening, quash it because it's actually really sophomoric and it prevents us from really getting the work done about how to improve outcomes. So that's number one. This slide, I think, represents that. But the other thing that's interesting is instead of looking in medicine and saying, wow, we're really irrelevant, my question is, how can we be more relevant by better understanding those red wedges to optimize our value and optimize our impact so that no matter what we do in taking that 10%, we're actually having real impact and change. And for the folks who are not in the medicine kind of downstream service delivery sector, how do you make sure that we take this science, this knowledge, and exploit the heck out of it so that we can no longer be on the defense, right? And say, having to plead with healthcare or to ask for some little bit of resources as they fall off the table. Let me move on then. So the social determinants of health are what that provider was asking about. If we can go to the next slide really quickly. The upstream efficacy gap really is what I was talking about, though. It's not that providers out there don't know these issues matter. It's just that they don't know what to do about it. 4 years ago, the Robert Wood Johnson Foundation did this great landmark study. They looked at over 1,000 physicians, and they asked many questions related to unmet social needs. And one of the questions was, how important do you think social needs are compared to health problems? to my surprise, my colleagues and physicians said, 85% of them said that they thought social issues were as important as their patients' health problems. Their patients' social needs were as important as their medical needs. I was blown away by that. I didn't think my colleagues were that progressive. But here's the more shocking thing, and this slide represents it. While 85%, and if not higher in some kind of subpopulations, if the vast majority of physicians knew that these issues mattered, only 1 in 5, 20%, felt like they had any sense of how to do anything about it. This is that gap, right? Hence the pain of that email, hence the frustration, the jaded cynicism, the burnout that we see in providers. Next slide, if you don't mind. The way this translates, by the way, this is going to be, we're going to pivot from the doom and gloom into an uplifting moment in about 2 minutes. So we're almost there. You guys okay? Good. This is what that upstream efficacy gap means for patient care. Just show of hands, the triple aim, is that something that you guys talk about it a lot, or is it just one of those academic things that somebody else talks about? The triple aim. So lower per capita costs, better population health outcomes, right? Better patient experience in terms of quality and satisfaction. The triple aim. People have started talking about the quadruple aim. Anybody hear about the fourth aim? Provider satisfaction and joy. I'm not kidding. It's now part of the literature. It's starting to. So you might start seeing the quadruple aim, and if you like that, which I do, then start saying quadruple aim. What's interesting is that this story of Veronica, my patient Veronica, illustrates why the upstream efficacy gap is actually a crucial thing that we need to help address if we're going to achieve the triple or the quadruple aim, if we're going to achieve that sense of impact as well as joy, frankly, in our work. So Veronica's story in a nutshell is this. This is a real patient. I had the privilege of caring for her about 3.5 years ago now in South Central, in that FQHC, the Federally Qualified Health Center. She's asked me to change her name, and she asked me for reasons that she has to block out her eyes, but everything else is true. Veronica came in with a chronic headache that had been lasting for about 3 years, on and off. This episode was one that had gone on for about 3 weeks. And before she came to our clinic, she had gone to an emergency department in Los Angeles about 3 weeks before she came to see us. In that ER visit, the doctors, the nurses, the clerks that cared for her ended up saying, Veronica, the tests that we've run are normal, quote unquote. We didn't have records being transmitted. This is all patient report. The results are normal. Here's some Vicodin. Follow up with your primary care provider, and if the pain persists or if it worsens, come back. Have you guys heard that kind of mantra before in the ERs? Maybe even seen those exact prescriptions for the exact issues. So Veronica had already tried, of course, the primary care safety net in South LA, and had come up short. And so when the pain did persist, she diligently followed instructions that somebody in a white coat told her about. So the pain persisted, so she said, I'm going to go back. I'm still not getting relief, so I'm going to do the rational thing and try to go back to the healthcare system. The healthcare system, by the way, right, the value proposition and what we imply is that if you are sick, come to us and we hope to make you better. Right? That's the basic sum of the value proposition. So she rationally chose to go back to the facade of the healthcare system, the ER. And not just once more, but twice more, a total of 3 times in 3 weeks to 2 different emergency departments in LA. And each episode ended like the first. Normal results, pain medications, follow-up. When she came to our clinic, she was exasperated, right? Because not only was she still sick, which in and of itself is a huge dilemma, but what had happened was that her frail mother was being called upon to help take care of her 2 sons, one of whom had pretty bad asthma that was flaring up. Her employer was getting more and more skeptical about the time that she was taking away from work, was understanding, but Veronica was worried about losing her job. At this point, a few years ago, the bill from the first ER visit had come back, and it was more than 1.5 times her monthly rent. Right? So she's now not only still sick, but she's actually exasperated. And it's because of the interactions with the healthcare system, right? It's not in spite of. And so she walks into the clinic. Now, again, this is a common enough story. This is part of the reason that that first email came to me, because that's exactly the same type of response that I would often have in my FQHC, right? Holy crap, there is somebody who's been sent in, fallen through the cracks right now. Thank goodness there's a safety net, but I'm in that safety net. How do we take care of this? Anybody have any records of what's going on? Anybody know how to deal with this? It was just this her story was like many stories that we saw every day. For me, it was 26 patients a day. That was my average. I was a medical leader in the clinic. I had to demonstrate productivity in the classic fee-for-service environment. So I knew I had about 12 minutes to deal with Veronica. This story, by the way, is far too common, and I'll tell you about the pivot to the good news in a second, but one of the things I had done when I got so frustrated at this point was I went to go find the culprit. I wanted to find the villain, right? Who dropped the ball in the ERs that ended up having a patient like Veronica end up in a clinic? I mean, there's world-class care supposedly that she's been accessing 3 times in 3 weeks. What's going on here? Why is she still not better? And why did you have to send her to a already under-resourced community clinic? I went through the records that I could find, and I found 2 things. One, I found people's handwriting was worse than mine, which was actually a surprise. I thought I took the award for that. But I also found this other issue. I couldn't find a culprit. There was no one person. Everything I found actually indicated that everybody swam in their lanes, right? Everybody was doing what they would consider to be the scope of practice. Doctors were giving the right advice, ordering tests that seemed to be legitimate. Everybody was doing the right thing, operating within the standard of care. But the compelling and troubling fact was that, in fact, instead of finding one culprit, in fact, what I had found was that, of course, we were all culpable. Somehow we had figured out, in the richest nation on earth, in one of the richest cities on the planet, how to marshal our resources, our talent, our brains, our hearts, to provide a mediocre standard of care. Right? Heroic. And obviously really troubling, right? So here's the pivot. Right before I met Veronica, something actually had happened that tweaked the system just a little bit. It was like taking this frame shift, right? You're in this one mode, and then something just alters, and then all of a sudden it gets you a whole different impact. What had happened was the medical assistant, who was doing her job, vital signs, asking about the chief complaint, headache. The medical assistant asked a couple of more questions that we had derived from the American Housing Survey to identify risks for slum housing. Because months earlier, I had sent out a very methodologically sound tool called SurveyMonkey to community stakeholders and asked a couple of questions. The key one was, what conditions what social and environmental conditions should we as a clinic in this community be better aware of in order to improve outcomes? When I shared this story, by the way, that question, at like large medical centers in Los Angeles and other parts of the country, I asked this follow-up question, which is like, when's the last time you guys did that? And of course, there are CHNAs, but very rarely do those CHNAs turn into, in my belief, yet actionable kind of changes in terms of workflow, right? The community health needs assessments. Anyway, what came back from that SurveyMonkey tool was a series of answers from a lot of community stakeholders, leaders. And what they said was, the number 1 issue was slum housing, number 2 was food insecurity, et cetera. And so that became my marching orders. I said, well, that's what I'm going to do. I signed up to be, a healthcare provider in this clinic and work in this team. Let's try to see what we can do to address that number 1 issue first, and we'll figure out what we can do. So we found the American Housing Survey, derived some questions from it, got 7 questions, and the medical assistant asked Veronica and many patients like her, who are from the kind of geographic hotspots where we knew slum housing was a big issue, which pretty much covers all of South Central Los Angeles. We said, do you have mold, water leaks, roaches, et cetera, et cetera? And Veronica had said yes to those 3 out of the 7 questions. So when I got the chart in hand, by the way, this is before our EMR implementation. I'm going to tell my grandkids at one point that I once touched a chart. So when I actually held the chart, this is now right after lunch, right? Food coma setting in. I see the chart. I see it's a thin chart, new patient. Vital signs are stable. Chief complaint is a headache. Oh, and mold, water leaks, and roaches. Okay. Now again, food coma setting in. Most of my blood flow is in my belly, not my brain. But something started to trigger, right? The data, both from the biologic sense as well as that social data, started to churn in this brain that a lot of money's been spent in training to provide healthcare. And I turned the handle on the door and I went in the room and I met Veronica. I got that story that I just shared with you. But what I immediately did was, after saying hello, was to notice Veronica's face. And for those who can't see, she has this crease across the bridge of her nose. It's called the allergic salute. You guys all know what that is. You see it in kids oftentimes who have chronic allergies, right? Or if you have allergies, you know that feeling, right? It comes from rubbing your nose up and down, and it creates a crease. No one in the records previously had actually documented that physical sign, from what I could find. Within 12 minutes of asking Veronica some questions, examining her, learning more about the headache and the history, and more importantly about her housing, and ruling out some other causes, I said, Veronica, I think what you have is what you know you have. You have chronic allergies. You also have some sinus congestion, I think, and I think what you have is migraines. Revolutionary, right? I should have called my mom and been like, look, it took that many years of training to come up with that incredibly profound diagnosis. This was not House, the TV show, right? But Veronica did two things. One, she had a sigh of relief, because sometimes when you're in the system that we are in right now, giving a diagnosis itself can be therapeutic. And secondly, I said, Veronica, here's some treatment, right? Prescriptions that will take care of those symptoms, but wait, I'm going to refer you to a specialist. It gets better. And she said, no, I don't want a specialist, doc, thanks so much, because that means 9 months of waiting on some list to get into the county hospital to wait to see the specialist. That's who she was thinking about as a specialist. But I said, no, Veronica, the specialist I'm talking about is a community health worker who, if it's okay with you, will go visit your home, understand what's going on with those roaches, mold, water leaks, and then help to mitigate those issues. And if required, we'll refer you to another specialist that I call a lawyer. A public interest lawyer who will actually work with you if it turns out your landlord is not making the necessary remediations. We'll partner with them. We've got this form letter that's going to go out to the landlord that kind of has the nice doctor speak about why this issues matter, and then also cites the relevant housing code, and we'll collaborate together. She said, okay. 3 months went by. We called her back in the clinic. It was a fee-for-service clinic after all. I couldn't get, the clinic would not bill for phone calls, unfortunately. But we called her back in the clinic, and she said her symptoms had improved by 90%. More importantly, her son's asthma had improved. Remember that? I didn't order an asthma medication for her son. He had been taking some from another provider, but his asthma improved. She still had her job because she had not missed any more days, and she was more productive and felt better. She was working with that public interest lawyer not only to have the landlord make the necessary changes, which had happened, but also to actually take care of that bill from the ER visit that came in. Most importantly, what had happened was that our housing had gotten better too. Our home had improved. And it improved because of what we had done. And so the next thing I did immediately was to call the medical assistant into that room with Veronica, and we did a happy dance. Because when you get a glimpse of what that was, which is a better standard of care, think about the triple aim or the quadruple aim, right? Lower costs for Veronica, lower costs for the system, better outcomes in terms of health, as well as housing, and lower costs to this, better quality of patient experience, she was happier with how she was feeling and her experience. When we knew that we were part of that, we made sure we celebrated the fourth aim, provider satisfaction and joy, because when you're on the front lines, as you guys know, there are rare glimpses that you get into this, and when you do get it, it is incumbent upon us to provide systems that allow us to celebrate, right? So at the very least, if you forget everything else I talk about today, just remember to go do a happy dance when you see that better standard of care, because that will be the fuel that will get us to the next happy dance and the next and the next and make it more common. There is a better standard of care that's possible, but how that happened was simply a frame shift. Prepping our system to screen patients for issues that matter in that community around social issues. Revolutionary, right? It's common sense, but somehow it was revolutionary in our clinic. The next slide, please, if you don't mind. So here's the thing. Many of you might be saying something like this. Some of you, you're probably not like this, but a lot of people in medicine, when I share this story, they say, fine, okay, listen, you got me, fine. I get it. Social determinants matter. Yeah. But they often say then, listen, I don't have time for social determinant stuff. I mean, social factors, housing, transportation, come on. I'm a nurse, I'm a doctor, I'm a care manager, I'm whatever, right? Have you seen the stack of papers in front of me, or have you seen the unchecked kind of files I have to go? Have you seen the work I have to do? Come on, social determinants, I don't have time. It's going to cost too much. Anybody hear something like that before? Next slide, if you don't mind. The truth, of course, is that that's also one of those things not to buy into, right? Because the truth is that it's already costing us too much not to integrate social determinants in care, as Veronica's story illustrated. So this is a triple aim, and let me just reframe the costs of not integrating social determinants into this connected way that you guys have been alluding to. The costs of not doing that are profound if we think about the costs, not just for Veronica, but millions like her in terms of money out of pocket, money out of the system, health outcomes, and of course, better quality of care, better experience. All of these things that we see in terms of preventable illness and health disparities, the wasteful spending that occurs in healthcare, and to a large extent, the patient distrust and also the provider dissatisfaction are in large part, I believe, and I know from firsthand experience, due to this lack of integration. We're already paying through the nose for not thinking about social determinants. So instead of saying it's costing too much to do this work, the right answer is it's already costing us too much not to do this. And by the way, it's a better standard of care, and I use this frame a lot, feel free to share it if you think it helps you as an organizer. When I talk to my colleagues in medicine, I say, look, I already know what a de facto mediocre standard of care looks like. If you want to defend that, by all means. I'm talking about a better standard of care. Don't you want to do that instead? We have to start to co-opt professionalism and standards of care, these terms that often keep the right thing to do at bay, and actually use it to advance the right way of doing things. The next slide, please. Veronica had become a high utilizer. A lot of you deal with high-cost, high-need patients, the sickest of the sick, right? Care management for intensely sick populations with complex needs. Well, a lot of innovation, of course, is happening, and the impact is happening for those patients because of the social work, the social determinants work that you guys know better than most. But the honest truth is that many of the accolades that are going towards the high utilizer, the hot spotting approaches that are taking place, often miss the underlying kind of truth, which is, yes, that's true, that's vitally important work. But it also is a sign and a symptom of a deeper lack of integration. Veronica had become a high utilizer because we had not asked about her home earlier in the process. We made her into a high utilizer. So instead of spending money only on high utilizer interventions that are innovative, let's talk about what we can do to actually prevent that in the first place. Next slide. So it doesn't take a genius to be able to ask this question. All right, fine, if we want to move to this new way, how are we going to do it? Well, everybody's getting paid for the old way. Fee-for-service environment, show of hands, what is fee-for-service? What dictates a lot of the payment incentives for you guys? Capitated? Anybody who works in a capitated environment? No? Apparently no one gets paid for your work. So in the fee-for-service kind of space right now, right, it's hard to do these things. Let's move to the next slide, and I'll pick up the pace a little bit. I think if we're going to move to the new way, we need to talk about stories, staff, and systems, right? And then, of course, the tools that support all three. The story is important because if we don't reimagine who we are, then we can't get to new ways of being different, right? We can't practice differently if we don't think differently. So the story I told Veronica and a lot of my colleagues there was not about social determinants of health. It's a horrible tagline. Try saying that 5 times fast, right? Social determinants of health. It's not something that wraps your mind around it. Instead, I just shared the parable that many of you are aware of. Anybody heard the Upstream Parable before? Oh, good. All right, so here's my adaptation of it, and now it'll be gospel because you guys haven't heard it before. 3 friends come to a river. Can I have somebody from the first row just raise your hand? I need a name. That's all I need. You don't have to do anything else. Sir? Martin. Thank you, Martin. And somebody from the middle over here, somebody, sir? Mike? Martin, Mike, and then somebody back over there, please, if you don't mind. Somebody in the back of the room over here. Anybody from the back? Yes, ma'am. Marlowe. Totally not planned. I want to do a stand-up thing now. This is great. Martin, Mike, and Marlowe. It's the first time that's happened. That's awesome. No relation. So the 3 of you guys come to this beautiful scene. It's just unfortunate because what happens immediately is you see people in the middle of the water who are crying out for help. So your afternoon stroll has been ruined right now, and of course you guys do the right thing. It's what you do already in your day jobs. You guys jump in and to try to save these people in the water. The young, the old, everybody in between, right? They're crying out for help. You jump in to rescue. Is that right? Right? Yes, good. Okay, good. We can get some more caffeine. What ends up happening, though, is over time you realize that there needs to be a smart approach to do this. So the immediate response that Martin puts into place is saying, you know, I'm a really strong swimmer, and you guys agree, and Martin goes down to the edge of the waterfall and says, I'm going to rescue those about to drown, those in dire straits. That works for a while, and everybody doubles up resources to invest in Martin, and everybody on the riverbank says, that makes sense, let's do that. This is, of course, who would argue against rescue? Mike, over time, says, you know what, I'm going to coordinate the branches off of the riverbanks here and build a raft, because maybe we can usher more people to safety before they end up in need of rescue here. People say, aha, that's a great, Mike, brilliant, awesome, let's do that. All of a sudden, the success rate goes up a little bit, and you're feeling pretty good. But over time, you realize, wait, there's still people slipping through, right? And over time, after continually rescuing people, getting them on the raft or rescuing them from that downstream waterfall, Mike and Martin look to each other and they're like, I'm getting tired. You guys don't say this, but other people out there in similar rivers start getting a little jaded, a little cynical, right? They burn out a little bit. They start looking for other rivers to jump into. They start doing things that are really uncanny. Again, not you guys, but other people will say things to people in the water like, didn't somebody teach you how to swim? Didn't your mama teach you better? Weird things like that start happening, right? Largely because you're getting fatigued. Anyway, over time you realize that while the success rate is going up and you're still nobly staying in the water, this is heroic, sacred work. You realize that Marlowe isn't anywhere to be seen. And you finally spot her. She's far away from you guys. She's almost in the back of the room. She's in the water. She's not like strolling along on a picnic. She's in the water. She's saving people as she's going. She's doing the work in the same river you're in. But she's swimming away from you guys as she's saving people. And Martin and Mike, you guys shout up to her and say, Marlowe, where are you going? There are people here to save. And Marlowe shouts back, I'm going to find out who or what is throwing these people in the water. In the healthcare workforce right now, we have the downstreamists. We have the specialists, right? Those vital, necessary components of the workforce, the trauma surgeons, the ER doctors, the ICU nurses, the care managers, right, that do intensive case management work. Those are the people that we need when we're in dire straits. We need many more of them, especially in places that don't have enough because of disparities. It's not that those aren't vital components, but we know that's not sufficient. We're in the moment right now, we're in Mike's moment right now. This is the comprehensivist. The primary care medical home, the care team that works together right now to create that raft to usher people to safety, get you those clinical preventative screenings, get you that access to other ways in which you can stay away from need of rescue. But we do know that in the healthcare workforce right now, there are many people out there, and I know this firsthand because I'm one of them, and I suspect that you guys are too, that there are many people who are not just downstream rescuers or comprehensivists building rafts, but there are some, not a lot, of people in the healthcare workforce who are like Marlowe, who are trying to systematically understand and address those social determinants of health, understanding what or who is throwing people in the water. Next slide, if you don't mind. And one more time. The healthcare workforce right now is incomplete if we only think about the two components. It's to really optimize population and level impact and to create that connected care universe. We not only need the right technology platforms in place, which is vital, but we also need the right way of looking at the workforce, which is one that includes not just the downstream specialists or the comprehensivists, but fundamentally upstreamists. The upstreamist is a specific job of a person or a team who is dedicated to optimizing the system by making sure that we're routinely screening for the issues that matter in that community, just like we did in Veronica's story. Somebody's job has to be this, because otherwise it's nobody's job. And if it's nobody's job, then it won't get done, right? And all we'll do is rescue and raft build. I think we need to actually take a different look at telling the story of what the healthcare workforce needs to look like. And I say healthcare writ large: behavioral health, physical health, social services. Next slide, please. So let me skip ahead a couple of things just in terms of interest of time. And let's move ahead just a little bit. Elizabeth, if you can move over, maybe keep going through slides and I'll tell you where to stop. Right there is perfect. Thank you. One of the ways that we can talk not just about the story and the way to create new staffing models to optimize outcomes is also to look at the systems, right? And I think one of the things that's in the toolbox, especially on the physical, biomedical kind of part of the enterprise, is this quality improvement work. How many of you actually work in systems that have really robust quality improvement teams or sponsors, right? Show of hands, right? Now, if you look at large hospital systems that do the biomedical stuff traditionally, there's been a lot of resource investment in professional QI teams. But there has not been enough investment in looking at quality improvement and process innovation in the social services. It's just it's a horrible kind of disparity right now that exists. And when quality improvement really was this shift away from kind of quality assurance, right, into, which is like, where's the bad apple? Let's get rid of that person who's a bad apple, into let's look at the bad system and figure out how to change it, right? And use rapid cycle kind of tests of change to get there better. The problem is that quality improvement, just like other tools in medicine, have been used in a way that's very, very focused on just the biomedical volume-based things, right? How many people can we churn in and out, rather than can we improve health outcomes? What I think is happening right now is this growing interest among large health systems as well as small providers, that what we can do is upstream our quality improvement efforts at the intersection of community services, population medicine, and health systems. That those things can bring it together. And I'll just walk you through really quickly. So we're going to just go rapid fire, Elizabeth. So for example, what does an upstream QI thing look like for, let's say we want to improve outcomes for diabetic patients, but we know food insecurity is a driver. Next slide. We know food insecurity is a driver because the research tells us this. In a study in California, more than 27% increase of hospitalizations among low-income diabetics linked to food insecurity. People's money ran out at the end of the month. They took the medicines the doctors prescribed, but they skipped meals. Blood sugar plummeted, ended up in the hospital, right? Next slide. So we know these things matter, but what do we do about it? In the healthcare system, doctors traditionally get paralyzed, and clinicians in general get paralyzed. They're like, we don't know what to do here. You know, this food insecurity, no, I can prescribe a statin, or I can prescribe some medicines, but I don't know how to address food. What we know is that we can develop these interventions by actually first setting the target, which is, go ahead, next slide. Being able to say, let's develop a program, like any good quality improvement thing. We're going to plant a flag and say, here's where we want to move towards. So we're going to improve by 30% our screening rate, our confidence in our outcomes. Next slide. We're going to get ready. In other words, we're going to, next slide, do an assessment in our systems to find out, are our systems ready to move upstream? And I can share this with you guys in a slide deck later. Next. We then, before we even do the solution, we have to segment our approach. If you're going to have impact, next slide. If you want to have more impact, we need to segment. Sometimes there's this catch-all thing, like, hey, let's help everybody who has diabetes, or let's help everybody who has mental illness. That segmentation is required, not only looking at different population segments, but also looking at different levels of clinical opportunity, from the purple spot, which is the hot spotters, sickest of the sick, the ambulatory ICU, if you will, the AICU model, to the patients in a medical home, and so on. There's all these levels of segmentation that we must require of ourselves if we're going to have the rigor to do anything about this. Social determinants should no longer be something that's a hobby in healthcare, right? It has to be done rigorously. Next slide, please. It also means segmenting our interventions. This is a basic kind of presentation of something that has been part and parcel of the trainings I've been doing in different health systems around the country, helping clinicians who don't understand what you guys do, right? That this stuff is addressable, that we can actually move on these things, helping them to break down their barriers, to improve their efficacy by essentially saying, pick a box and start there. Most often, people will start in this left lower quadrant here. Next slide, please. As we're going through, once you get ready and segment the population, and then people, the important point is planning together. What traditionally happens in quality improvement or any kind of project planning in healthcare is that we end up setting the table and only invite people that we know, right? And then we end up asking ourselves later on, like, why didn't we come up with a better outcome? Well, it's because we didn't have the right people at the table. So one of the challenges, if you're going to have a bridge between community health and healthcare, is to make sure that the teams can work together. So in Oregon, for instance, next slide, they're using this tool, which is an online kind of collaborative canvas, so that now asynchronously you can have actually teams just putting their plans together, let alone using their EMR systems together. Just putting a plan together that helps them to state their assumptions about the people who have the problem itself, and next slide, about the root cause analysis. What we need to do is start to actually say, as you plan together, let's move our root cause analysis upstream. Next slide. And let's make sure that as we're identifying root causes that we can address that are in the social and living conditions rather than just the biomedical, that we now actually say, now we know how to implement our tools. So much of what's going wrong in terms of healthcare, getting the outcomes, is because we're not prepping before, we're not thinking before we act. We're just acting with the same tools. next slide. There are these tools out there that are screening tools that you guys are aware of. This is a free tool that we put together based on the Institute of Medicine recommendations that came out last year about how to identify upstream risks. Next slide. And I think what's clear is we need to, as we do this, and by definition, not just have healthcare at the table, but have the ability to build community partnerships and capacity right now. So much disparity exists between the resources in medicine versus the resources in community and social services, that what we need to do is make sure that while we partner together, that we're not actually imposing unnecessary burdens on less resourced partners, right? We have to build if we're going to partner in a true fashion. This last thing is an example of actually what that can look like. In South Central Los Angeles, about a year and a half ago, we did something that I called the outside-in play. We got 100 high school students over a course of a year, 30 students in each class over 3 classes. Each of them went through a 3-month program that their teachers led and we supported. And what ended up happening was the students did a couple things. They learned in a very kind of Freirean way. You guys know the participatory kind of education, right? Way. The students brought their experiences to talk about to learn about social determinants like housing or food. But then they mapped the resources on a very basic Yelp-like interface that we built for them. So now they're doing participatory mapping. Where's the WIC agency? Where's the housing agency, et cetera, in the community? And then what they did was actually the most important part, because that's not really innovative or groundbreaking. What was innovative is that those students then did this thing you can see on the bottom left. Those students went to UCLA Medical Center and they detailed the doctors. You guys have heard of detailing. Detailing is what the pharmaceutical industry does to doctors every day. They send in young, sexy people to talk about pills, and all of a sudden the rates of prescriptions for those pills goes way up, right? And the doctors say, oh, I'm immune to that, but here's another script. That food is really great. Let's do another, more Lipitor, please. We're co-opting that methodology and actually having the community detail the doctors around the social needs. What happened was not only the ability to triple the sense of efficacy among the providers who were detailed, because they were having high school students come in and tell them about the needs and the resources that exist and how to use the Yelp-like tool. But the most important thing was that the high school students themselves tripled their confidence to address these social needs in their neighborhoods and their families without the healthcare system. Building capacity. And we built in the model that we tested out to actually say, healthcare, you pay for this, right? These high school students are addressing your pain point, its value they're creating right now. Pay them for this work and have the money go back into the community. There's an interesting model that I call community health detailing. Last slide. When we put all these things together, actually we can do what we did even 3 years ago when it was kind of clunky in that clinic in South Central with Veronica. We almost tripled the provider confidence to address those issues. That upstream efficacy gap can be closed. And it can be closed when we realize that number one, next slide, Elizabeth. Number one, social determinants are a crucial component of getting healthcare right. It's a crucial component of actually getting healthcare as a right, because that's how you organize people. You don't organize people up here, you organize people where they live. And by addressing food and hunger and the things that you guys are doing. And lastly, we can only really invest more in social services upstream, not only by advocating for those things that invest in social services and instead of healthcare, frankly, but also by recognizing that healthcare itself can be a partner in this process. It's not an either-or debate anymore between public health or social services versus healthcare dollars. It's about doing that, but helping to build a constituency of supporters for an upstream movement in the US by being able to activate and optimize outcomes in healthcare. And I think it starts, last slide, it starts by just telling ourselves a different story of what we can do together and how we can start to think about what connected care really does look like. Within that new story, our tools, our technologies, our staff, and our systems can all start to actually finally maybe get a glimpse of a better standard of care. And I know it's possible because we did it for Veronica.